Thank you very much, Eric and Rosemary. We very much want to continue with the multidisciplinary theme, particularly here from a clinical perspective, and as well as myself, Kate Arron, clinical psychologist, will be presenting the bulk of the presentation, and with us in spirit, we're more broadly multidisciplinary than that. Joe Kilgariff, our clinical nurse specialist, has contributed to the presentation, but unfortunately can't be here with us today. And we're going to focus in terms of structure and outline, presenting on particularly moving on now to teenagers who are seen within community CAM services, and presenting on our assessment and intervention service for them. So in terms of structure and outline of the presentation, I'm going to kick off just to tell you a little bit about how we came about in terms of developing the service, and then hand over to Kate, who will talk you through the care pathway and the journey for the young person, right through from referral and initial screening through to assessment and intervention, all very much with a multidisciplinary perspective in mind throughout, and then some thoughts about outcomes and where we can go forward in the future from here. So just briefly in terms of context, the challenge, as for many services around the country following the publication of the NICE guidelines in 2008, was how services can best implement the guidelines, bearing in mind funding limitations and demonstrating value for money. And within our mental health trust, which is a large mental health trust serving a population of over about 1 million, looking at how this could be done to make a service that's as compliant with the NICE guidelines as possible, but also potentially as accessible as possible for children and young people who are under the care of community CAM services. So within our trust, as when any new NICE guidelines are published, there's initial scrutiny about how they can be implemented, and a topic expert group involving the NICE lead and some of the local clinical leads are set up to look in what ways we already meet the NICE guideline recommendations, but in what ways, broadly speaking, the trust are not compliant. So this piece of work identified a number of problems, some of which were more solvable than others. As in many areas, there are multiple providers for ADHD, and like many parts of the country, community paediatrics play a big role in terms of seeing the bulk of particularly younger children presenting with ADHD-type problems. But this can often mean that care pathways, broadly speaking, are unclear from the perspective of families, from schools, and from primary care referrers. Within CAMS in particular, provision was felt to be quite piecemeal, and often it meant that what you got depended on who you saw. So whether you were diagnosed and what interventions you received for ADHD very much depended on which clinician you saw and their level of interest and expertise within ADHD. And there was no coordinated or dedicated service for these young people. And in terms of putting research grants together, looking at local recognition and diagnosis rates, it was quite apparent overall as an area that the administrative prevalence of ADHD was somewhat below the national average. So again, this suggesting that many children who are being seen, perhaps the right diagnoses aren't being made and are not being picked up. So in terms of stressing the problem to apply for internal funding through our trust, NICE Uplift funding, we highlighted the problem, particularly that as it stood, that community CAMs were not sufficiently resourced or staffed to deliver and to provide the evidence-based care that NICE guidelines recommended, and that without some sort of dedicated multidisciplinary service, these problems were likely to continue, and particularly the problems of inequities in terms of recognition, in terms of diagnosis and interventions received. And highlighting particularly the clinical risks of this, because many of these children with ADHD are being seen by specialist services, but potentially these problems aren't being picked up and they're affecting their long-term outcomes and adding to their impairment. From the perspective of young people and their families, the key problems around unmet needs include that there'll be other risks, such as developing further mental health problems, potentially presenting in crisis when these difficulties can be preempted by appropriate signposting and assessment. In the long term, as Rosemary's outlined, and as we well know, there are long-term impacts on these young people's clinical, educational, and social outcomes, and a particular impact for trust services, because many of these problems are going to persist into adulthood, and there will be a demand for these services both in primary and secondary care for young people and young adults with ADHD. So how did we put the case forward to our trust? Well, in particular, what was clearly lacking was any sort of dedicated multidisciplinary input, and the NICE guidelines had recommended, and this is across the lifespan, not just specific to children and young people, that mental health trusts should form specialist multidisciplinary teams for people with ADHD, and these teams having clear expertise in diagnosing and management of ADHD. And in putting the case forward to our trust, we highlighted the areas in which the trust had been struggling, and that's particularly the delivery of non-pharmacological interventions, which were very much a cornerstone of the NICE guidelines, and also broadly multidisciplinary assessment and input. In terms of background consultation work, we consulted with GPs and paediatricians locally, and in particular paediatricians highlighted the need for there to be more readily available community expertise for ADHD, so that may be consultation or maybe direct work in terms of referrals. And that helped us to put the case together in terms of developing a small service around evidence-based assessments that could also provide some of the non-pharmacological interventions, such as parent education and training, school liaison, which we'll come into in more detail, and although there's quite a lot of expertise already in terms of medication, but some further input in terms of advice or initiation of medication interventions. In terms of assessing the potential impact of the service, well, firstly, from the perspective of young people and their families, we also consulted with local user groups. And they highlighted particular concerns, one about uncertainty about care pathways. So if you are concerned as a parent, where do you go to? How do you access services which potentially seem like a minefield and potentially feel very difficult to navigate? Particularly, parents also highlighted the very poor links between health and education services, so that children were quite often being seen within health services, perhaps not getting a diagnosis of ADHD, but then this not necessarily being translated into what they were receiving educationally, and that being quite a struggle with parents feeling that they were often having to convey information between clinics and schools. And our aim in terms of setting up the service, that broadly it should particularly improve the experience and the quality of care received by young people and families. Furthermore, in terms of making the case to our trust, where we were asking for some additional funding to develop this, we had to highlight the potential value for money in developing an additional resource. So particularly around reducing waiting times, reducing duplication around assessment, and improving signposting within services. From the trust point of view, clearly important across a whole range of NICE guidelines that as far as possible the trust is delivering evidence-based care as recommended by NICE. We highlighted the link between any service development and key objectives within the CAM's integrated business plan and key performance indicators going forward, and also the potential wider benefits of the trust in terms of clinician training and furthermore going on to developing fledgling adult services as well, because actually a lot of themes here are in common across ADHD in children and young people and adults with ADHD. We were relatively modest in our initial request, bearing in mind we're talking here about a total population of over 1 million in terms of developing an initial pilot multidisciplinary service. So we requested to develop a multidisciplinary service initially 1 day a week's time of a psychiatrist, of a clinical psychologist, and then a bit more 2 days a week time of another professional that could be clinical nurse specialist or occupational therapist in background, so that we could set up a weekly multidisciplinary clinic for assessment and be able to provide non-pharmacological interventions. And by doing this, adding value to existing CAMS work and existing value to clinicians who would be able to easily refer into such a service. So just very briefly, I'm just going to talk through who we've seen and how we've been monitoring the service. What's been very striking in terms of looking at numbers, we've been running now for a few years, but looking at who we see, comparing the last 2 years with the 2 years before that, there's been a definite shift. And particularly in that time, over the last couple of years, we're seeing more girls than boys, and the majority of whom we see are in their teenage years, age 13 or above. And this is very much in keeping with the clinically referred population increasingly seen by many CAM services now around the country. But obviously what this also highlights is that ADHD, being a developmental disorder and early onset, these problems have not been picked up and are not being recognised into the teenage years. And many of these young people are presenting into CAM services with a multitude of other difficulties where their ADHD has potentially been missed or sidelined. In terms of monitoring from a trust perspective, following on from the NICE ADHD guidelines, there are now a set of quality standards. And the key ones that apply to children and young people of this age firstly relate to children and young people with ADHD symptoms being referred to an ADHD specialist for assessment. Well, we're clearly now, and the Trust is fully compliant with that. Secondly, in terms of referral to parent training programs, again, fully compliant, either in terms of directly offering these or clear signposting to these programs that might be available elsewhere. The third area in which we've been more, I think, selective and judicious in terms of how we've interpreted the guidelines relates to children and young people themselves being offered a psychological group treatment program. And although this potentially could be set up, the way we've gone about it instead is actually offering individualized psychological intervention, which Kate will talk to in a minute. But because this has made better use of our resources, it's certainly reduced waiting and delays in terms of being seen, and can be much more individually tailored to the young person's need and potentially taking into account the other difficulties that they've been presenting with. So in terms of the process going right through from the referral through to the assessment and intervention, I'm just going to present the first aspects of this and then hand over. So how do we decide who do we see? Given potentially a large number of young people that are seen within CAMS, we're very flexible in terms of having conversations with a whole range of CAMS clinicians about possible cases that they might want to refer for an assessment. We do some background initial screening, particularly using instruments such as the Strength and Difficulties Questionnaire, and particularly from the school perspective, completing the Connors Teacher Rating Scale, and the Teacher Dorber, which actually has been proven to be very useful in terms of providing information on emotional difficulties and other behaviours, such as oppositional behaviours as well, so it gives a broader perspective than just ADHD. Gathering any other background information that might be available, and usually one member of the team takes the lead on that, and if there's any uncertainty, we'll discuss it with the other two team members. And in terms of using pre-assessment screening, there's some evidence behind this, and again, presented from our flagship ACAM journal, Childness and Mental Health, showing before and after work in other CAM services, looking at how scarce resources can best be optimized. So work has shown that it is feasible to screen all potential referrals using instruments such as the SDQ, and the Connors. And in a service that implemented such a screening, this was associated with a considerable increase in diagnosis rates of ADHD amongst children referred, helping to make better use of resources. But we are quite broad in terms of we're aware that even with using screening, many children may not ultimately get a diagnosis of ADHD, but are clearly presenting with other neurodevelopmental difficulties and other needs which may merit an assessment in their own right. So I'll stop at that point and hand over to Kate to talk you through what we actually do within the assessment and going then through into the interventions that we offer. Thanks.
Thank you, Kapil. So, as Kapil's said, the young people we see in our service have already been involved with CAMS, so they tend to come to us with a bit of kind of knowledge of who we are and what we do. And we do see young people together with their parents. They tend to come together for the assessment, and we have a bit of time together, but then we're able to do 2 simultaneous assessments, both with the parent and with the young person. And the parent session tends to take quite a traditional kind of clinical interview way of working, and tends to be Kapil that conducts that part of our assessment. And these are some of the things that you typically think about when you're meeting with a parent for the first time. When we're meeting with a young person, we tend to be a little bit more informal, and we think of every stage as an opportunity to gather information. And with the types of young people that we see, this might be anything from making a slice of toast to actually kind of doing some more formal assessments with them. And we are quite flexible, so in order to be able to kind of facilitate the young person to stay with us, that might mean that sometimes we're kind of moving around the building, we might be going to the shop if we have to, that kind of thing. Some of the more formal assessments that we do consider are the DIVA, which I will come on to talk about a little bit more. We also do try and get a little bit of information about intellectual ability, and that can be really useful if a young person has come to us with an idea that they're perhaps not achieving so well in school, they're perhaps behind expected levels, and it gives us a bit of an estimate of kind of underlying intellectual ability. We rely quite heavily on observations of the young person as well, and it's quite important. We'll be looking at their level of activity during the assessment, how much they're fidgeting, typical stuff, but we're also looking at their ability to stay focused. If they go off track, can we bring them back on track again? How this changes over the course of the assessments and those kinds of things as well. The DIVA then, we just thought was worth mentioning a little bit more, partly because it's freely available for people to use, but it gives really good close attention to detail. And although it is for adults, actually, because of the age group of young people we see, we find we can use it a little bit more if we think they're able to give us some good information. It does give really good examples of ADHD behaviours, down to things like organisational skills and forgetfulness, right down to the detail of if the young person is forgetting things quite regularly, what are the things they're forgetting? Are they forgetting their mobile phone, which is really important to them, or is it actually just their homework, which is perhaps less important? One of the other things that we've been really lucky actually in our service to be able to utilise is the QB test. And I think through our links with Kapil and the university, we were involved in a research project with the QB test. And it's a computer-based test. And the young person you can see here, a picture of this chap doing the QB test. And it has a little monitor on his head. And then he's just looking at the computer screen, watching for red and blue shapes appearing. And all he has to do is respond to a button when the shape on the screen corresponds to the one he's previously seen. It's it's 20 minutes long. That's all the young person has to do for 20 minutes. It is really, really boring, but that's the aim of it. And it gives really good information about all the core symptoms of ADHD. And it can be really, we've found that since we've been involved in the project, we have actually used QB testing more and more, because it just gives us really interesting, impartial information that are compared to developmental norms. If you ever get the opportunity to get involved in research projects that are going on, I would recommend it. We do rely quite a lot, I think, within our team on case discussion. And I think that really helps in terms of really bringing together that multidisciplinary perspective of our team. We aim to get together on the day of the assessment to complete a post-assessment case discussion, and all the information then's fresh in mind. It also reduces any delays if we think we need to gather something else. And obviously we'll be looking at any evidence of the core symptoms of ADHD, but we're also thinking about kind of psychological formulation. So the idea in the case discussion is to pull together all the different ideas, different information that we have, so that we can start to consider alternative formulations as well. Obviously, we do spend time looking at DSM criteria, which we use to make decisions about diagnosis. And then again, at the end, if we find that perhaps kind of the evidence about symptoms is consistent, perhaps between information we've gathered from school and parents or the young person themselves, or if we just feel like we haven't quite got enough information to feel confident in taking things forward, we do sometimes try and gather a bit more information, and if we haven't already done a QB test, that might be when we start thinking about it. One of the other things we also have found that's really helpful is going back to schools and saying, can you ask a few members of staff that know this young person to fill in a bit more information for us, so we can sort of see within one school environment, how does the young person cope in different lessons and situations. In thinking about our psychological formulation, we have a few kind of different areas in mind that we tend to try and draw from. So we'll be thinking about neurobiological factors, things like tics and a diagnosis of ASD, the young person's family history. Is there a family history of neurodevelopmental difficulties? Was there any exposure in pregnancy to toxins or stress? And we heard earlier about kind of different neurodevelopmental difficulties, and this is, when we're gathering this information, I guess what we're not looking at is factors that might make us think the young person doesn't have a diagnosis of ADHD. We're just looking at everything else that's going on so that we can bring all this information together. Developmental history of birth, milestones, all the normal kinds of things. Any early life factors that might be important. So we're thinking probably particularly here about early attachment experiences and potential barriers to that. Did the family experience anything like domestic violence? Have any of the parents got mental health difficulties? We're also thinking about family relationships. How do they all get on together? Are there any sort of strong family cultures that might be influencing how the young person functions? What's the young person's emotional well-being like? So, for instance, we recognise and we know that anxiety can have quite a big impact on a young person's functioning. It can affect their ability to concentrate. If they have, if they're experiencing social anxieties at school, they're constantly surrounded by people. So, might that be a factor in their functioning? And it can also be quite distracting for people if they're experiencing anxiety thoughts. And also what their experience of school has been like. Are there any relevant cognitive issues that might be affecting their functioning? And just generally, what's their experience of school being like? After we've completed the assessment with the young person and their family, and we've completed our post-assessment case discussion, when everything is kind of all pulled together, the first thing we do is invite the family back in and complete a feedback session with them. And this is when we first start to think with the family really about possible interventions. And these are all the different areas where within our service we've been able to sort of focus really and think about our different interventions. And when we're thinking with the family about what interventions might be helpful for them, we're thinking with the NICE guidelines in mind, but we're also thinking about our psychological formulation and everything else that might be going on for the young person. So thinking in more detail about these interventions, we might be offering interventions for the young person. And when we're thinking about the relevance of this, we might be thinking about the young person's age, their cognitive ability and their level of engagement in the whole process. And we tend to always offer psychoeducation, but we also draw from CBT. And then depending on our formulation again, we might be thinking about principles of dialectical behaviour therapy or dyadic developmental psychotherapy. And that's really thinking a little bit about the links between kind of early attachment relationships and ADHD. And also the evidence a little bit about kind of emotional regulation and those kinds of difficulties. We might be thinking about working with the parents, again, offering psychoeducation, parenting approaches, which is generally our colleagues, Joe's area. But we also, again, think about, back to that psychological formulation, was there anything going on for the family? What was the impact of the young person's ADHD symptoms on the family? Has it caused any wider stress within the family that we think actually they might benefit from a little bit more systemic thinking? And then really importantly, I think linking back to the local user group feedback that Kapil mentioned, liaison with school. Excuse me. So one of the things that we always do is try to have a direct liaison with school. Excuse me. So, as I was mentioning, Joe, our colleague Joe, does quite a lot of work with schools and with parents. And I think we all agree that the work that he does with the psychoeducation side of things is a really, really important part of what we do. And it does start in a way at the feedback session with the family. Sorry, excuse me. When we're sharing our draft report and talking about the symptoms that the young person is experiencing. And we offer psychoeducation to all the people that might be involved in the young person. So the young person themselves, we talk with them about ADHD, the parent and the school. And one of the most important aspects of it really is about building empathy for the young person from the people around them, but also from the young person themselves. By the time they get to us in CAMS, they've often had a very difficult time and things have been very, very difficult, excuse me, for a long time. And if people around the young person perceive their ADHD behaviours as more defiant or oppositional, then it's often received with intolerance. Whereas if the young person can be understood, then the difficulties are much more likely to be received with empathy, and people are much more likely to be able to adjust their behaviours to accommodate the young person's needs. When we're thinking about psychoeducation, we start off with general information about symptoms and neurobiology. And this can be quite important again because it can prevent internalisation for the young person. It helps them understand ADHD a little bit more positively as well. So hopefully rather than thinking, I'm naughty, the young person can start to think, I've got a really fast brain. And my colleague Joe, again, he draws on an analogy from a psychologist, a Canadian psychologist, about the fast car, leaky brakes. And he said, ADHD is like a sports car with high-performance, fast engine. However, the brakes aren't very good, so you don't stop quickly enough. And often young people that we see, they know they've been struggling with things for quite a long time, but they don't know why, and so they internalise it. they think it's because they're naughty or they're stupid or they're not as good as other young people. So it's really important to be tackling those beliefs. One of the other things that we also do, particularly with young people, is talk about celebrities. So this is the faces of people who, according to our sources, have publicly confirmed their diagnoses. Don't know if anyone recognises anybody there. Well, this is who they are. And I think particularly for the young person, it can be really nice to see some famous people as role models. I think ADHD, the label of ADHD often carries with it ideas about poor outcomes. This is all from Joe, actually. I didn't know who some of those people were. But the celebrities can kind of be motivating, I think, and can perhaps give young people who have come to us in quite difficult times perhaps a little bit of hope. Our school-based interventions then, we do direct liaison with schools wherever possible, and we often try and get quite a few members of staff to meet with us, particularly in secondary schools, which is predominantly kind of where we're seeing young people. And it can be quite a lot of people sometimes. But what we try to do is talk with them more generally about ADHD, but also make things relevant to the young person. And one of the things that we do tend to focus on a little bit more in schools is executive function. And we were just hearing from Rosemary whether that's as linked to ADHD as we perhaps thought it was. But in terms of thinking for teachers, what it can do is it can help them understand ADHD in terms of what will they see for the young person in school, what skills will it impact on. And in secondary schools as well, I think there's a growing expectation on young people to be able to do quite a lot for themselves. Growing independence, so they can organise themselves and get themselves to lessons and have everything for that lesson that they might need. So this is just a list of kind of some of the things that we talk with schools about. And we also spend a bit of time with them thinking about whether there's any members of staff that they might have in school, like learning mentors or behavioural support staff, that can help the young person, perhaps in a structured classroom assessment, but also at unstructured times. We talk a little bit about strategies as well, provide them with information in a booklet about neurobiology, and also thinking about the positives. And we found it's really helpful to leave something with schools for them to kind of come back to and think about. And in some schools, we've even found that they've actually really taken this and kind of photocopied it and passed it around and haven't always had as much information about ADHD as we thought they would have done. And we have a list of about 20 to 25 helpful hints that we've pulled together from work that we've done and the evidence and the literature, but also actually from teachers that have worked with young people with ADHD. And so here's just a couple of examples. And we do have I think we have two versions of this now, one for primary school staff and one for secondary school. And again, I think it's really important to think about the positive attributes that you might be more likely to see in young people with a diagnosis of ADHD. Spontaneity, spontaneous and enthusiastic are the ones that stand out for me when I'm thinking about young people with ADHD. And I think ADHD, again, because of the label, and I think it's often thought about in terms of the deficits and the things that young people can't do. It is really important to really highlight the young person's strengths and use those in a school environment. What might they be good at? So our parenting work then, and we won't go into too much detail about this today, so I think we have that as a topic later on today. We tend to draw from 1, 2, 3 Magic and Surviving Your Adolescence. but we offer it on an individual basis rather than a group basis. And that's partly because of the numbers of young people we see, because we're such a limited service. We've got very limited resources within CAMHS. We found that although offering it on a group basis might make sense, actually to get enough punters through the door doesn't always kind of work out. And again, this is the area that our colleague Joe often does. And I think what he also tries to do is where he thinks it might be helpful is to be able to signpost parents to other services within CAMHS or within the local area. I suppose the other area where our service is probably slightly different is that, and again, this is more about us trying to bring in those different disciplines into the work that we do, is we try and think a little bit systemically. So we know that ADHD or a person in a family experiencing ADHD can put significant stress on family systems. And it can often lead people to developing some quite unhelpful ways of relating, especially if that young person's difficulties haven't always been understood. And so we started to really recognise this and think about ways of working with families around this. And so sometimes Joe and I will be able to work together with a family where we're bringing in perhaps some of the parenting kind of more traditional parenting strategies and approaches from perhaps 1, 2, 3 Magic. But we're also giving the family the opportunity to understand and appreciate the difficulties that they've been experiencing, to build on their strengths and to perhaps go on to make some useful changes. So Joe and I recently actually worked with a family with a teenage girl with symptoms reaching criteria for ADHD. But our psychological formulation suggested that these symptoms were having a really big impact on her relationship with her dad, particularly. And so our initial work was just with mum and dad, and this is still quite time-limited brief interventions that we do, but rather than going straight into 1, 2, 3 Magic, we spent a couple of sessions with them early on, just trying to understand the difficulties, perhaps trying to help them adapt their expectations of their daughter a little bit and recognise the impact of her ADHD on her emotions, on their emotions, on how they then communicated with each other as a family, so that they could think about how to change that a little bit. And it was interesting that as a family they had sort of quite strong, I suppose, hopes and expectations for the future that this diagnosis had changed quite significantly for them. So recognising what that meant for them and just being able to help them to move forward, really, using their strengths. So the last intervention, I suppose, as a team that we want to talk about today is the individual sessions. And they are quite short. We only offer up to 3. Occasionally we can be flexible to 4 sessions with the young person. And we have to be quite strict with that time, because the young people we see coming into CAMHS, they're older teenagers often. They've got quite a lot of complex difficulties, and we can offer a short-term intervention. So we have to work quite hard, really, on prioritising a specific area to work with. And our aim is, as a service, to try and focus more around the young person's ADHD, perhaps, than all the other things that are going on. But I suppose we have to recognise that ADHD doesn't exist for that young person in isolation of everything else. So we might think a bit more flexibly about kind of the impact of those things. And for the CBT approaches, we tend to draw on the Young and Bramham work, which I'll go on to talk about a little bit more again. But where the young person might be experiencing, so it's where their formulation indicates the young person might be experiencing more kind of difficulties linked perhaps to attachment relationships, or they're perhaps emotional regulation difficulties and quite struggling with distress tolerance, that kind of thing. We tend to draw a little bit more in the session on particularly dyadic developmental psychotherapy. So I might be using principles from that in how I communicate with the young person, just to help them kind of build that trust and that engagement. I don't know if people are very aware of the work by Young and Bremen, but it's quite a nice model in terms of being able to link together the symptoms of ADHD. So when I'm doing this kind of work, I will be meeting with a young person, helping them to understand these links, really, between those early neuropsychological, the neuropsychological deficits that might be poor response inhibition, difficulties concentrating with their life experiences. So how is that interacted with their life experience? Might be educational difficulties, social difficulties, with specific triggers. What are the actual triggers that linked, the triggers that start off a difficult interaction? And the triggers for young people with ADHD are often linked to specific social situations like conflict, confrontation, jumping to conclusions, or exams, things to do with their inattention side of things. We then work with a young person to look at the patterns of behaviours. So this is the way that sort of Young and Bremen have tried to sort of demonstrate it, I suppose. And it's thinking about, due to these negative experiences, people with ADHD tend to be prone to negative appraisals, behaviours, thoughts and feelings. And this cycle can kind of go on. And the aim of the work is to be able to, kind of using cognitive reframing and restructuring ideas, bring them into more positive ways of thinking about themselves and acting. So just as a very quick, hopefully, example, I worked recently with a young girl a couple of years ago with a young girl who was 15, and she was brilliant in that she really quickly understood the principles of this. She was able to link up the executive functioning problems with life events. She was able to recognise the cycle that happens for her, so she was very quick to react to conflict in quite a defensive manner, and to assume that people were judging her. And she recognised that she was much quicker at this, and that her thought processes would go from whatever it was that had happened to some negative appraisal very, very quickly. And actually what we did was, kind of using this understanding, she was able to prevent the situation. She recognised her triggers, avoided them a little bit, just to prevent difficulties, and took herself off. So break times was a particularly difficult time for her at school. Took herself off to the nurture unit. So she didn't avoid conflict at all. She avoided a situation that often led to conflict. But then when she was faced with kind of conflictual situations, she could do it in a supported environment where there were people around her, where she felt safe. And so she was able to sort of give herself the chance to learn some skills, really. I think Young and Bremen would probably say as well that they do tend to draw, in their work with young people with ADHD, more from the behavioural side of CBT, perhaps than the C. Outcomes for our service, I think, is an area where we are working on. It's a work in progress. At the moment, we rely quite heavily on the KIS, and we do this post-assessment with families, young person and parents. Because the work that we do in terms of our interventions can be quite individualised, we found it harder to find kind of one outcome measure to use across all the work that we do. So we tend to be a little bit more individualised. But as a service, CAMS, where we are, is moving much more towards goal-based outcomes. So we're trying to mirror that and think of that as a way forward, really. As a service, we try to spend quite a lot of time, because we're such a small resource for such a huge population. I guess what we're trying to do is think about getting the best out of that resource to provide the best service for young people in the area where we are. We have thought about group-based psychoeducation sessions for parents separately, perhaps, and for young people. So that's one of the ways we're thinking about moving forward. And again, I think, our outcome measures following interventions is an area that we need to start focusing on really. Thank you very much for listening.